Hey everybody, welcome back to the ECG channel. My name is Reed, and here we've got today's ECG. Go ahead and download it from the description. I've got the file link there so you can follow along, and like and subscribe if you enjoy these videos. So let's get started with this EKG. So first thing we're going to do, like always, is we're going to look at the forest, and the trees of the forest are our QRSs. And so what we'll notice is that it appears if we go down here to maybe this V5 rhythm strip here at the bottom, we can see we've got a narrow QRS, and then we've got this wide QRS, and then a narrow, and then a wide, narrow, wide. Kind of occurs in that similar pattern, and then we just go to this narrow complex, regular beat here. So we've got some funky beats that we need to come back to, and it appears that there are some P waves just as I kind of look in front of the narrow beat. So it seems like there's some sinus activity, there's some narrow QRSs, and the rate of my narrow QRSs, if I look at it, maybe my R lands on that solid line. So 300, 150, 100, 75, just over 75. So probably 80 beats per minute. And so let's take a look and see what else we can find with this EKG. So next we're going to evaluate our atrial activity. And so our atrial activities are P waves. And so I do see, like we said, some P waves. And those P waves are upright in lead 1 if I go up to lead 1, and they are upright in AVF. And so these are sinus P waves. Next thing we do is we're going to evaluate the next piece of our conduction system, which is our AV node. Our AV node is represented by the PR interval on this EKG. And so if I zoom in back down here to lead V5, I see that I have P waves that conduct to the QRSs. It appears that those P waves conduct with a PR interval, that is greater than 200 milliseconds. And so we know that there is some type of AV block because of that. So now we need to figure out what type of AV block is it. Is every P wave conducting to a QRS? Are there any Ps without QRSs? And I don't see any Ps without a QRS. I just see a PR interval that is prolonged at the same length of prolongation without a drop. And so according to this EKG, this would be a first degree AV block where our PR interval is prolonged. And so the next thing we're going to do, kind of measuring the rest of our intervals here, we'll look at our QRS interval, the duration of our QRS really, and we did say that was narrow, and if I zoom in on a QRS, maybe here in V1 on our narrow QRSs, I see that the QRS is less than 120 milliseconds, and so that's a narrow QRS. I need to look at my QRS axis. I see my QRS is upright in lead 1, but it's down in AVF, and so if I look at my heart over here, that means that it's going to the left because it's going up in 1, and it's going from inferior to superior, so it's going superiorly because it's down in AVF. And so my QRS axis is somewhere up and to the left, so that's a more of a left shift to our axis. And so what things can cause left axis deviation in the setting of a narrow QRS? So I know there's not bundle branch blocks. I don't see an incomplete bundle branch block, and left bundle branch block would create left axis deviation. And I look over my lateral leads, I don't see an R prime in my lateral leads, V5, V6, lead 1, or AVL. But I do see that I've got, in lead 1, I've got this QR pattern. You can see got a QR pattern, and I've got this RS in lead 3. And so that is criteria for a left anterior fascicular block. A left anterior fascicular block is the left bundle branch, in fact, splits into the left anterior fascicle and the left posterior fascicle. And so this is a left anterior fascicular block. If you need to know more about those, I do have a lecture on those. So we've got a left anterior fascicular block, which explains our EKG axis. My QT interval, I'm just going to eyeball it. Usually I like to measure my QT interval. I measure an R to R here, and if my QRS lands at least halfway down, then I say my QT is good, and that kind of helps correct for the rate itself. And so scan through looking for pathological Q waves. I don't see any ST or T wave changes. And so now we need to go back to these funky beats that we said that we need to figure out what are these. Well, first thing I need to do is, are they premature, are they not premature? And so if I take the QRS here in lead 2, we'll look at lead 2. So here's one of my normal QRSs, here's my next normal QRSs, and if I split it halfway, I would expect for the next QRS to be right around there, but it's early. So these are, we would say, premature. So now we need to figure out, are they premature, are they premature atrial contractions? Are they premature junctional contractions? Or are they premature ventricular contractions? Those are really our three main types of contractions. That just tells us where they're arising from. And so first thing I want to do is I want to notice, are they wide or are they narrow? And so these QRS durations, I see they are wide. So that really kind of knocks premature junctional contraction off of the table, because a junctional contraction is going to have the same morphology as, or very similar morphology to our normal conduction down the AV node into the ventricles. So now, you know, it's a wide complex QRS, so we think it might be a PVC, because we know PVCs do not take the normal His-Purkinje system. But what I need to do is I need to make sure that there's not an atrial P wave that conducts aberrantly through the AV node into the ventricles. And so I do notice, if I look in front of each of these wide funky beats, I do notice that I do have this atrial P wave, right? We would say these are all sinus Ps. So they do have P waves in front of our QRSs, but does that mean that they conduct to the QRS? And the answer here is no. The reason being is because if you look at a normal QRS, it's a normal beat, you see we've got our normal P wave, and it conducts with, we said, a first degree block. It's very long, right? And if we look at the next one, it's very long. But in this case, look how fast that P wave, if it did conduct to the ventricles, it does so in a very, very quick interval here. And we know that our AV node is diseased to the point where we have this first degree AV block with a very prolonged PR interval. So even if we did have a P wave that was causing these QRSs, we would still expect the PR interval to get longer. We wouldn't expect for the AV node to all of a sudden conduct that beat better. And so because of that, this wide complex QRS is a PVC. This is a premature ventricular contraction. And so I really just wanted, for the takeaway for this ECG strip for you, is to really learn how to evaluate these three, the PAC, the PJC, and the PVC. You have a systematic way of going about it. And that's going to help you, because in this case, PVCs typically don't have P waves in front of it, so we needed to figure out, are these P waves driving these aberrant QRSs? And in this case, it wasn't, because we understood the health of the AV node. So let's put it all together. What do we have? We've got a sinus rhythm with left anterior fascicular block. We've got a first degree AV block, and we have PVCs. If you want to say even further, we've got the PVCs in a bigeminal pattern, because it's every second beat. So that's ventricular bigeminy. So I hope this EKG helps. If you have any questions, throw them in the comments. Don't forget to subscribe, and we'll see you tomorrow. Have a great day.